I will chat recording progress. Maybe there was more than 70 participants registered. Maybe they will attend lately, so we can start. I'm delighted to welcome each and every one of you to this highly anticipated Zoom webinar on mechanical thrombectomy for stroke access in different European countries. It is truly an honor to have such a distinguished and diverse group of participants joining us from different corners of the globe. Whether you are a seasoned professional in the field of neurointerventionist, a dedicated healthcare provider, researcher, or simply someone with a keen interest in medical advancements, your presence here is today invaluable. The topic is both timely and crucial as advancements in medical technology continue to reshape the landscape of healthcare. This procedure has become a revolutionary intervention in the treatment of the acute ischemic stroke, offering a new hope to patients and challenging traditional paradigms in the stroke management. Throughout the course of this webinar, we'll have the privilege of hearing from leading experts in the field who will share their insights, experience, and research findings. Our esteemed speaker will cover a range of topics from the historical evolution of mechanical thrombectomy to the latest innovations and breakthroughs in the field. Together, we will explore the impact of this procedure on patient outcomes, its potential challenges, and the future directions of research and development. Before we begin, I would like to express my sincere gratitude to our speakers for generously sharing their experience, as well as to our partner ISMINT, European Society of Minimally Invasive Neurological Therapy, for their support in making this event possible. Before we begin, please mute your microphones. As you know, we have 8 participants. All of them have 10 minutes for a talk. You can leave your questions in the chat and don't forget to mention the participant. And after the presentations, I will read your questions. So if Dr. Iago has some words to say, after that we can start our webinar.
Yeah, you can start, Lars.
Okay, our first talk will be from Dr. Vladimir Kolosek about mechanical thrombectomy for stroke access in Croatia. Dr. Vladimir Kolosek is head of the Department of Radiology, subdivision of Interventional Neuroradiology, Clinical Hospital Center Sisters of Mercy from Zagreb, Croatia. Dr. Vladimir, you can share your screen and start your talk, please.
Thank you, Lasha, for this nice introduction, and I'm glad to participate in this webinar, and I hope with our presence and my talk that we will help you in developing your program in Georgia as well. And I would like to thank you, Jakob, once again for this invitation. So can you see my screen? Can you see the presentation?
Yes, yes.
Yes.
So the topic of my talk will be stroke network in Croatia, how it's developed and how it's going. So maybe you know by looking at the map that our country is shaped like a banana, and in that shapes we needed to decide and to see which centers can be start up to make area for more patients reachable to have the service of mechanical thrombectomy. So we have on mainland, we have 2 centers. One is in capital of Zagreb, and one is on the east of part of the Croatia in a town called Osijek. And on the coastline, we have one in the northern part, which is a harbor city called Rijeka, and on the lower southern part we have a second largest town in Croatia called Split. So in Zagreb we have 2 centers which provide a whole whole capacity of neurovascular procedures. One is a center in which I work, which is located on the western part of the city. and one is located on the eastern part of the city, which is in the biggest hospital in Croatia called KBC Rebro. And they started the neurovascular procedures in Croatia in 2003. We joined them in 2011, and we together do all of aneurysm, AVMs, and stroke treatment. We started in Zagreb with stroke treatment around 2015. We started before that, but more we started after those studies in 2015, and our number has steadily grown, and I believe this year we will reach all together in Zagreb around join with them around 400 mechanical thrombectomies. As you know, maybe by the news, our population is now, according to the latest number, around 3.9 million. Rijeka started to provide service for northern part and mid coastline in 2019. Split has started year before that in 2018. The guys from Rebro went and spent some time with radiologists in those cities for a few months to educate them and educate neurologists as well how to approach to start the service of mechanical thrombectomy. Also, as I come back to this slide, you know, we have the diverse.
Dr. Vladimir.
Sorry.
Your slides are not working. We are stuck in the first slide.
Okay. Can you see? Can you see now? Can you see the third slide?
No, it doesn't.
We see just the first slide.
Okay, I will stop and share again. Sorry. Sorry, I must.
For a brief moment, we had it. Yeah.
Yeah, now we
Can
see.
you see now? It's on.
Yeah.
Okay, so so we can continue. So Split started first after the Zagreb in 2018, then started Rijeka in 2019, and also they provide service for all the islands which are near to those cities, which is a terrible nightmare to organize the emergency transport, because then you are relying on the helicopters which are provided by the military, and we have very few of them, and also you need to rely on the fast boats which are in ownership of the police. So it's a logistical nightmare, and also this nightmare is expanding throughout the summer season, when the population on our coast is increased by five times. So in the last city which started was Osijek on the east part of the Croatia in 2020 during the COVID, and in that time they did 50 procedures that year, and now all of those three cities are around 100 procedures. They are performing around 100 procedures per year, depending how the year went, and with those 5 centers our whole country is covered. This year we saw increased numbers of all of endovascular procedures, and that we saw that steadily growth after the COVID ended in 2021 and the beginning of 22. We had during the COVID a little bit decrease in aneurysm treatment, which is increasing in 2022 and 23, and also with that the numbers of mechanical thrombectomies are increasing because all the education of the patients and the
Dr. Vladimir, it says the third slide.
yes.
Yeah, okay.
And that is due to the increase of awareness and also the arrangements with the smaller hospital to ship the patients to our centers and also to their centers as well, and also due to the education of the fellows from neurosurgery, from neurology, and from radiology in our hospitals, which they during their residential fellowship in our hospital, they are getting to know what kind of procedures we are doing, especially in mechanical thrombectomy, for what patient there is a selection of, is there any selection at all? And so that help a lot, and their awareness and our friendship with them made also with younger physicians possibility to get in touch to us via WhatsApp and messaging quite quickly, and then the more and more patients are referred to us. And so the last slide for me is that we are in huge demand for trained neurointerventionalists to have a full country coverage, because only 2 of us in my hospital is fully neurointerventional trained, and in other hospital in Zagreb there are 4 of guys, and that's 6 neurointerventionalists in Zagreb. But in all of those other cities, the mechanical thrombectomy is performed by peripheral interventional radiologists, and there is a demand in all of those cities for more and more people to perform, because we are not in we have on calls which are technically regulated by law, but the law is not obeyed here, and we have months with 300 hours of on call, which is true nightmare. And beside that, we need even more to make effort to better hospital triage and faster transportation to stroke centers. So we have seen, and it's known that the numbers are showing that we are doing a good job, but you can improve, and we are going to improve even more in the future. Thank you. That was all from me.
Thank you, Dr. Vladimir. If there will be some questions, attendees, please write down in the chat box, and I will read these questions in the end of our webinar. The second speaker is Dr. David Hernandez from Catalonia, Spain. He is interventional neuroradiologist, our good friend, and his topic will be the direct transfer to angio suite. Please, Dr. David, share your screen and start your talk.
Okay, can you see the slides?
Yeah.
Perfect. First of all, thank you, my friends, for this kind invitation. I will try to short my lecture because it's a little bit longer, but I'll do my best. Okay, here is Catalonia in red. This is the northeast part of Spain. You see it in the pointer. This is Barcelona. This is where my hospital is, Vall-d'Hebron. In Barcelona, in the area, we are almost 6-7 stroke centers. So all of them do thrombectomies. Something good we have in the Catalonia is that we have a public registry of our strokes. You can Google it and you can enter and see our numbers. If you see these numbers are from 2016, yes. We did in total Catalonia less than 400 thrombectomies. 6 years later, it was 3 times more, so it's going more and more. All of us know that time is rain, but I'm going to talk just our workflow. There was a paper in 2019 that they found that the total time of from the onset to the puncture was 38% of total time was the intra-hospital flow. It's a lot of time. When the patient came to the hospital, it takes a lot of time until we start the procedure. If you see here below, even it was in that paper, it was worse in direct admission patients because people transferred from other hospitals. They knew they had an LVO. Okay. Looking back to our numbers, we checked them and then we saw, okay, door-to-brain puncture in Catalonia it was about 70 minutes. If we know 38% of that time was workflow in hospital workflow, we thought, okay, we can improve it. There were some papers just telling us that direct transfer to angiosuite was faster, obviously. But then our colleague, Manuel Requena, make this nice paper, direct to angiography suit without stopping the CT. And we made a randomized trial. It was called AngioCat. Okay. We have two options. The patient arrived to a hospital, then it goes to the CT, there is an LVO, and then we treat the patient, or we skip the CT and go directly to the angio suite. Our inclusion criteria was patient with a suspected LVO, raise higher than 4. Raise is a scale used by our medical emergency system, less than 6 hours. We were pre-notified by the emergency system. Then when the patient arrived at the hospital, we confirmed there's an AH more than 10. And then with a good functional independence premorbid. And then we randomize the patient. So patient arrives, we randomize them, 50% goes to the CT, 50% goes direct to the angio suite. And our endpoint was the ranking at 90 days. Okay, this is an option A, going directly to the angio suite. Patient is discharged from the ambulance. The neurologist is there waiting for the ambulance, examines the patient. Okay, it's suspected LVO. Then go directly to the angio suite. We rule out a convinced CT. We check there is blood or there is no blood, and then we do the treatment. On the other hand, the other option is going to the CT, make the CT, look at the CT, they make the CTA, and then if it's suitable for treatment, the treatment. What you're looking at here is the new machines have a very good combing CT. Those CTs are from a Philips machine. Okay, on that study, the outcome was the first endpoint, ranking at 90 days. Then we also check our times, door to arrival to brain puncture, the recovery, the mortality, and safety outcomes. And our results. We had 174 patients, half and a half to angio suite or to a CT. All the patients were quite similar between the two arms. More or less the same LVO. Previously to that study, we practiced a little bit. We had, I think, 200 patients, and we found that if we took the patients direct to the angio suite, maybe 90% of the patient didn't have an LVO. So you have to know that probably if you put the patient in the angio suite directly, some of them will have intracranial hemorrhoids, and some of them, when you do the first run, you will see there is no occlusion. Okay, coming back to the last study, patients were quite similar. something interesting is that when you do a CT, that time we saw 12% of the patients, we saw low aspects, and then we decided not to treat the patients. But when you put the patients direct to the angio CT, because it's not as good as a standard CT, all the patients were treated, 100%. The number of passes were the same, also puncture to reorganization time. The most important part of all of this is the reduction of 42 to 18 minutes from door to puncture. So we skip a lot of time going directly to the city, directly to the angio suite. Okay, the safety outcome, there was less mortality in patients who went to direct the angio suite. Not, it's just a tendency, a tendency toward that, but it's something. And the most important part was the ranking scale at 90 days. Look at the differences between when you put a patient direct to the treatment and when you waste some time in the city. Okay. Conclusion, patients with an acute ischemic stroke by LBO with less than 6 hours direct to angiography suite, reduced in hospital delays, increase the odds of undergoing the vascular treatment. That's what I told you. If you look at the CT, standard CT, you will see maybe too much information. Aspects will be worse. And if you do it in a convenient CT, it's a good option because you won't see that so black brain, and you will treat the patient. Now, after that study, okay, we thought, can we do it better? So now we have a new assistant process. We changed all of our service. We've been a year waiting for that. Now we have it. And what we have is this. We have our angio CT and your angiography in your CAD lab. You can see here there is a CT. So we can bring the patient into angio suite. And without moving the patient, we enter the CT. So video, we enter the CT towards the patient. So it can come. We can do a standard CT. We can do a perfusion if we need for starting, if it's if you want to check some perfusion, and then we treat the patient. And we don't waste time moving the patient from one side to another side of the hospital. And we have new objectives. We want to reduce our times from the arrival to the puncture. We want to have better recanalizations. There are a lot of objectives we have. Just for finishing, this is a small video. It was in 2016. We started doing the direct transfer to the angio suite. It took 10 minutes preparing the patient. Since the patient arrived to the angio suite and we started the procedure. And now we improve it a little bit with 2 minutes less. Okay, that's not important. Just what we know is that everyone is ready for when a patient arrives. So our technician knows what to do. Our nurses know what to do. Our fellows knows what to do. We are all like a Formula One team, preparing to change the tires from an F1. And that's all. have any questions, we will answer later. Thank you.
Yeah, thank you, Dr. David. Our next presenter will be Dr. Ivan Vukasinovic from the Belgrade, from Serbia, from the Clinical Center of Serbia. Dr. Ivan, if you are ready, you can share your screen and start your talk. Yeah, Dr. Ivan, can you hear me?
I hear you.
Yeah.
Just a sec, so sorry.
Yeah.
I had too much things on my screen. Nice, so I need to close them on. So, anyways, I'm very proud that that you made this webinar and to be with you here today, and also to be able to make a webinar a part of the EastMint project, and the webinar itself is endorsed by EastMint. Just a second.
Yeah, it's a great honor for us to.
Yeah. So without further ado, just tell me if you see my my screen. You see it? Something has blocked. Oh, sorry. Do you see it?
Yeah.
Full screen? Yeah.
Yeah.
Changing slide. Okay. So just a couple of words about the incidence. You see here the global incidence of acute ischemic stroke. You see that in the developed countries, it's far less. And you can see it in Serbia, where I'm from. It's more than the average global incidence. So we have a bit of, let's say, epidemiological crisis. We have younger and younger patients developing acute ischemic stroke, even children. So it's something that the epidemiologists need to look why. You see in Belgrade we have a number per year of acute ischemic strokes. What is the situation in Serbia? 7 million inhabitants. We have 4 comprehensive stroke centers and 1 primary stroke, let's say primary stroke center, but not comprehensive, but it has a cath lab and everything. It's dedicated for the acute ischemic stroke and hemorrhagic stroke. So this hospital does also works. In Belgrade, there's 1 comprehensive, 1 primary stroke center. In Novi Sad 1, Niš, Kragujevac. So you can see this is the map of Serbia. It's very well distributed. And in Belgrade, we have around 2 million inhabitants, or 2 million in catchment area. So you can see how many mechanical thrombectomies is estimated in 7 million inhabitants in Serbia. It's far less that we reach today. The procedure is is recognized, it's approved by state, and it's completely reimbursed, so it's free for our citizens, no charge. There is no national strategy yet, but it's on developing, and also no registry. And I think it's very important to have a registry, as David showed. So I think we need to do it in each country so we can track what's happening. So this is the numbers. In Belgrade, we have 250 cases per year in these 2 centers. Other cities are doing slowly, let's say, but the numbers are increasing as we should expect. In Belgrade, I said 3 million inhabitants, 3 million catchment area. So 3 stroke units, and as David showed, in Barcelona or in Catalonia, the stroke care organization depends on local geography. So this is for example of Paris. They have a rotational shift. So every day also, let's say, night or a weekend. The other part of the city is on call, so they can rest and repose themselves. In Belgrade, we also have this asymmetrical rotation that's proposed. So we are doing 3 days, working days, the other hospital 2 working days, and then we shift the weekends. We have 3 weekends, and the other hospital 1 weekend per month. So it's a way to, you know, to rest and to not overload our staff. In our hospital, so we began with the neurointerventions from 2007. We were hardcore, you know, neurointerventionists doing aneurysms, AVMs, everything. And then we were a little bit late for the thrombectomies. I think I had in 2017 the ESMINT scholarship or fellowship. Well, I learned in Toulouse with Christophe Cognard and Christine Jean-Noël how to do it, how properly to do it, and then came back and we lifted up the service of we added mechanical thrombectomies as such. So I think, as Vlado said, this education for the youngsters or in our centers, also abroad, is very important. And in ESMINT, we will do everything to help and to support that for the older guys from the Middle Eastern Europe. More than 2/3 of thrombectomies are outside working hours. So as mentioned, we do it in parallel, which is very important, not to lose the time, not to do one thing and then wait on other things and so on. We don't have this AI fancy programs. We'll probably have it next year, but we use the ordinary, you know, networks like WhatsApp or Viber, it's not commercial. And then we communicate in our group, and we are aware that such patient came in our center, in our emergency department, and we are ready to come if the CT or CT perfusion, CT angio shows that we need to do it. The neurologists are the ones that receive the patients. They send us the pictures, as I said. We have this discussion and make a common decision. It's very important to have a good relationship with neurologists, at least in our country, and then we have it, and then everything goes smoothly. We of course we don't fight. We get a mutual agreement for the decision. How to say the time? Well, direct admission to some dedicated emergency department. We don't have it. We don't have yet the direct to angio. IVTP done in CT. We don't do it. We do it after the CT, while the patient waits for us, and then we continue in the cath lab. For drip and ship patients, we usually don't repeat the imaging, only if it worsens or you know, drastically improves. And why we try to progressively provision mothership. It's not it's not that big city. You can come in half an hour or 1 hour, or if it's a traffic jam, then that could be a problem. What we do, we have a nurse technician. And both are called by neurointerventionist, who is informed by neurologist. Anesthesiologist, we don't have it regularly, so we do it in a local anesthesia, meaning just at the site of puncture. If the patient is really very unrest, or if posterior fossa or something that needs to be intubated, of course it's intubated. But there is a lack of anesthesiologist in all our big hospital, and the need is really high, so we don't do it regularly. So as I mentioned, we do it in a local anesthesia. We have now 2 biplane, and we have 1 hybrid, as that shows. So we have 3 cath labs, and it's very near to CT now in a new building that we constructed recently. We do the CT CTA. We don't do the MRI for the initial imaging, and of course CT perfusion for 6 hours plus. And we do, as I said, the most cases under local anesthesia. 1 day after that was follow up with CT or MRI to see how is the situation. And this is very important. We from the beginning we're doing like this. So we need the blood pressure, systolic blood pressure between 140 and 180 during the procedure, before the procedure, before the recanalization, After reclinization, we drastically lower blood pressure, meaning below 140, very aggressively, not below 120 or 100, but it needs to be lower than 100. It save us 140. That save us from a lot of complications. And recently, a couple of cases ago, like say 2 weeks ago, we had a patient where it's a situation where you will see that. So the patient came and I was late. My younger fellow became procedure. There was an anesthesiologist there, but it was not a real anesthesiologist, but no specialization. Is he couldn't handle the blood pressure, but I was not aware of that. So we did the reclinization, and then you see what happened. So this is on the cath lab. The patient get worse, and we did the cons beam CT, and you can see the very drastic example of the blood-brain breakthrough, blood barrier breakthrough. And I think that's important to have this blood pressure between 140 and 180. Here we had this is a mistake between 190 and or 210. And that will happen even more when you do dejections of the contrast media. Then you heighten the blood pressure going into the brain. So the patient got worse and eventually died. So you need to take care of that. For the wake-up strokes, we of course do the CT perfusion, and we don't care if it's a tunnel lesion. We do tunnel lesions as well. These are our numbers. Let's say this is the average number. You can see that we have a very low IVT number. 70% should be around 60% if you look at the big randomized controlled trials. The reason is that they're not eligible patients or they come late. So the population is very vulnerable. They have comorbidities, and they're not very regularly. They're not aware of that. So we don't do IVT for the different reasons, and this is something that could be discussed in the developing countries. This is also a problem. Door to AP was terrible, 120 minutes average. The reasons are many. So these all steps are really tough to be coordinated sometimes, and you need to educate your own colleagues. I said every 6 months or something, just to tell them how to do things in parallel. Otherwise, it's a nightmare. We compared the two centers, Toulouse and Belgrade, in the first 2 years of doing thrombectomies, and you can see that we are almost the same in MTK reclinization percentage, around 80%. There was no difference in the symptomatic cerebral hemorrhage. NHS was comparable, and then you see the difference. Also, the 3 months MRS 0 to 2 was almost the same. Let's 10% difference, but no statistical difference. But in 3 months MRS, you see the big difference. So 29% of mortality. Now it's a little bit lower, around 23%, as we looked, but it should be much lower. So odds ratio is 2 here. So 2 more times likelihood for the patient to die after ischemic stroke, after mechanical thrombectomy in Belgrade and in Toulouse. And this is that interplay of stroke severity, comorbidities, and socioeconomic factors, which is lower than in developed countries. And also this fine randomized control trial from Brazil showed that also they have also 25% of around 25% of mortality. So the patients from MRS 4 and 5 are shifted to the MRS 6. The usual MRS 0 to 2 stays the same. No age limit, of course, but the human children might know. This is the patient from the other neighboring countries, the former Yugoslavia country. And then you show the patients 11 years old. You can see 30 hours from the beginning that he came to us after, with the helicopter. You see the basilar artery, which is blocked at the midpoint. So this raises eyebrow to there's something going on at the basilar artery. He came to us as this example, and then we did the first pass, and you see something strange at the middle of the basilar artery. Then we looked, we always wait, and then you see the new thrombus forming. It was a dramatic situation of what to do. And then from this experience from France and other private centers, so we did some little bit bolus of agrostat, stabilized the clot, and the patient was well. Otherwise, we need to stent this lesion. So this is the situation. He was rapidly improving, and you see that it was really a dissection afterwards. This is the one year follow-up. In posterior circulation, of course, as said, we should do it. The problem is when to decide when it's too late. When we don't do it, when there are no reflexes of the brain stem. Otherwise, we do it. We had the patient from a complete coma that recovered. It is futile to do it, but sometimes futile, but not dangerous. And for the tandem occlusion, so these are the questions: to stent it or not, or MCA first, or the lesion encountered first. Of course, we need to do it. All the studies show that there is 80% of unfavorable outcome if do it only with the IVT or not, or follow up, or not do it anything. So this is for one example for the patient that had occlusion on one side. You see the previously stent in the side, and then also big stenosis on the other side, occlusion. And then we passed almost everything was going, all the blood was going from posterior circulation, and then we were able to pass this occluding site and just to do the intracranial occlusion, and then we left it like this. Usually you leave the stenosis and the occlusion because the brain is, or the circulus villus is adapted, and then we do just intracranial. If we need to do it, and then in second pass we do the carotid lesion. And this is the outcome. So as a conclusion, very good news. As Vlado said, we need new youngsters. We have now 4 of us. That is not a bad situation. Previously, we were 2 of us. It's very tough. Our specialty, because of mechanical thrombectomy, is very attractive for the younger generation, and I think it's a very big field for the research in the next 10 years. So we will see what the future will bring us. So thank you, and come to Serbia when you can, and we host you, and it will be a pleasure for us.
Thank you, Dr. Ivan. Actually, I was in Serbia 1 year ago to the Dr. Lukas Rasulic in the peripheral neurosurgery. So I spent there a month. It was a great pleasure to meet a professor. So thank you for this lecture. And the next lecture will be the Professor Andrei Netlyukh from Lviv, Ukraine. He works in the Danilo Helitsky Lviv National Medical Center University. Sorry, Professor Andrei, you can share your screen and start your presentation, please.
Okay, thank you very much for the invitation to participate in this meeting. It's a pleasure and honor for me. I would like to present some issues about our situation in Ukraine and in western part of Ukraine. Here my affiliations, it's the Danilo Helitsky University and as well First Territorial Medical Association I will mention later with unit. So you know the burden of stroke in the world and in the Ukraine as well. It's the major medical problem, and we population during last years, and since 2021 it like more than 10 millions, another 10 millions of people. Now actually we have 28 up to 34 depending upon the source of information. population, but nevertheless, the stroke is become more common. As you see here, more than 100,000, 35,000 cases per the last 2022, year 2022, and among them, the majority were ischemic strokes. Mortality is still high in Ukraine. During 2023, it was near 17%. Total number of strokes, as I told, is presented here, and the IVT procedures are during last year up to for Ukraine. Western northwest of Ukraine consists from several regions, and the total population is about 10 million of people. Lviv is the biggest region here, 2.5 million. As you see here, centers that do actually thrombectomies in the western part of Ukraine. Lviv, Lutsk, Kovel, and Volyn region are the leaders actually. Maybe I have no the most recent data, but I asked every colleague from cities to renew it, and the information that is here is presented. You see other centers, they are involved, and they actively use this technology. I think the question of time to make more and more procedures. About 2.5 million population, and as you see here, except of Lviv, we have a few stroke units in small cities in regional hospitals, and a few of them have angiographic suite, Drogobych and Chervonograd here on the northern part, and it is good news that they did first 4 mechanical thrombectomies during last few months. In Lviv alone, we have 2 major centers that do emergency procedures for patient, and the third one is approaching. They wait for the equipment, and another hospital, big hospital, but still has no angiograph, and they do just thrombolytic therapy, and they have some neurosurgical facilities. So, because of location of hospitals in many 91% of the territory within 60 minutes of the distance to get to the hospital. Goals in Ukraine are more than ambitious. As you see here, we have to achieve up to 2030 18,000 of IVT procedures annually, and AVT should achieve 6,000 cases. It, according to the plan of European Parliament, so-called CEP, they put these goals. We are close, but still, of course, not above these numbers. So in Lviv, we have 3 hospitals in First Medical Territorial Union, St. Panteleimon Hospital, where I'm working, in St. Luke Hospital, and for children we have St. Nicholas Hospital. In St. Panteleimon Hospital, actually, we have 3 angiographs. In St. Luke, 1 angiograph, and St. More and more of procedures. It's not enough, of course, according to population, but it's rise, and we do everything to make it for any patient who is in the therapeutic window. During a few last years, we've got a new equipment. It's very important for the effective work. We have 64 Philips CT, 128 general electric CT. As I told, we have several angiographies, and we've got a new one recently. Our stroke team. Everybody knows that teamwork is the key for effective treatment. Once patient get to emergency department in our hospital, he go directly to computer tomography. During CT, after native CT, we check aspect score, and intensivist they start IVT indicated, and radiology start angiography, CT angiography, and call to our angiographic department. We consult patient during next 5-10 minutes and make decision about the intervention. We have a department that consists from 130 beds, neurological, neurosurgical, and intensive care beds. It was the COVID location on the base of this department during the COVID pandemic. In the Ukraine, we have the reimbursement for people with stroke, and it was less during last year, down to 400 euros, and for IVT we got 1,500 euros and 3,200 euros for Indova therapy for patients with ischemic stroke, and as well during last year we got the reimbursement for patients with subarachnoid hemorrhage who need embolization of aneurysm or AVMs. We have many hospitals in Ukraine in total making MT procedures, and some of them are located on the eastern part, doing heroic work during the war. Lviv is up of the European goal. We do mostly 6% of cases with thrombectomy, but of course we need to improve our results. What about complications? The most of them were side problems. In some cases we deal with distal embolies, and a few cases of intraoperative extravasation and vasospasm. In total, 24% of clinically of them, of course, were fatal, because I will show later the mortality rate. So site occlusion, the majority of cases was located in proximal M1 of MCA, mostly left side. As well, distal MCA, tandem occlusions, proximal ICA were noted in our patients. The time from onset to admission was a little bit higher than we hoped it should be, of course, because 115 minutes, it's too much. And time from admission to cath lab to groin puncture was about 19 minutes. So we have to improve as well these parameters. And the MTC2B3 was achieved up to 88% of cases, and clinical where the mortality rate was about 18%, and patient MRS 0, 1, 2, 3. So with good result were noted in 55%, 56% of cases. More than the half of patients were independent after treatment. To save time, as told previous lecturers, we have to do many things. In our country, it was the pilot project of medical evacuation that has been stopped because of work condition. And now it does not work, but it started to work 2 years ago, and we got a good result for timing of these patients. We do different maneuvers to get the thromboextraction. and you know about it, everything. Aspiration at first passage was effective in 20% of cases, primary thrombectomy 40. Percent of cases passage needed to treat was around 2.5. We have actually 32 cath labs working as neurointerventional cath labs in Ukraine, and we await for new angiograph for neurointerventions that have been purchased already and will be commissioned in the next 10 months. 11 Philips Azurion 5 and 3 Philips Azurion 7. You see here the location that will be used to put them, but in the western part of Ukraine, we wait for 4 new devices, and one of them will be put in Lviv, and we hope it will work effectively. So I will save time, just a short case about a young lady with acute onset of dizziness, and she were diagnosed with left vertebral artery PC, the occlusion of left VA, and from the opposite side, critical stenosis of right one. So was made the decision to make thrombectomy from the left side. After thrombectomy and stenting, because critical stenosis was noted here as well, got a good perfusion, and 3 months later we did a control angiography with good stent patency, and the stenosis was left for follow-up. Right side stenosis was left for follow-up. So the MRI after procedure, but patient get well, and MRS1 was released from hospital. Thank you for your attention. Good luck. Merry Christmas to everybody, and have the peaceful life. Thank you for attention.
Thank you, Professor, for this great presentation. Our next speaker will be Dr. Denis Bulya. His topic will be mechanical thrombectomy for stroke access in Bosnia and Herzegovina. He's head of diagnostic and interventional radiology department, clinic of radiology at Clinical Center University of Sarajevo, Bosnia and Herzegovina. Dr. Denis, you can share your screen and start your speech, please.
Okay, thank you. Thank you very much for your introduction. I hope that you can see and hear me clearly.
Yeah.
First of all, I would like to thank the organizing committee for inviting me to give a talk about stroke management in Bosnia and Herzegovina, and I would like to wish you all Merry Christmas and Happy New Year. I will now share my screen with you, and I think you can see my presentation now.
Yeah, we can.
Okay, great. I will, as already told, I will speak about stroke management in Bosnia and Herzegovina. I have nothing to disclose relating to this talk that I'm giving to you today. And I will start with the major game changers in stroke management. All of these studies actually happened in 2015, and the results of Mr. Clean were actually published during a conference in Istanbul, and they were published. They were printed in New England Journal of Medicine on 1st January 2015. So after a few unsuccessful studies that actually failed to prove that doing mechanical thrombectomy is actually the right thing to do in patients with stroke. These studies showed the results and promised a brighter future for stroke patients. So If we go further in time, so a few weeks ago, actually, the interim results of tension study were released. So according to this study, we can actually treat all patients, no matter of their aspect score, within the time window of 24 hours. So the results, the trial was actually stopped early because of efficacy. So how about in Bosnia and Herzegovina? So we're in delay in comparison to the rest of the Europe. So these are actually the numbers of IVT that were provided during the year. So you can see that in COVID era, actually, those numbers were significantly low, and things actually started to improve in 2022 and in first 10 months of 2023. We witnessed substantial growth. Still, it is almost uncomparable to the results in other European countries. And of course, it reflects with the numbers of mechanical thrombectomy. So, for example, the first one was actually performed by my team in Sarajevo in early 2021. And in 2023, two centers in Bosnia and Herzegovina, Sarajevo and Mostar, are actually performing thrombectomies. And so far, we had in the first 11 months, we had 88 mechanical thrombectomies, and I have to say that actually this number is higher because some things actually changed in Sarajevo over the last 3 weeks in terms of management. So we started to perform more thrombectomies. So, for example, we had like 4 thrombectomies in 10 days. So Mostar actually led so far in number of thrombectomies, partly because it was funded by the Croatian government for this endeavor. You all know about primary and comprehensive stroke centers, and I have to say that actually Sarajevo and Mostar are comprehensive stroke centers. We have availability of advanced imaging techniques. We have personnel trained in vascular neurology, neurosurgery, and endovascular procedure with 24/7 availability of this personnel, and with the capabilities of neurological intensive care unit facility. This is the map of Bosnia and Herzegovina, and as you can see, the two comprehensive stroke centers are located in the central, eastern, and southern eastern part of Bosnia and Herzegovina, and there as well two other centers which are so far primary stroke centers with Tuzla, promising to become third comprehensive stroke center in near future. So there are no private hospitals so far, and the majority of the population actually gravitates to those 4 centers. However, the problems that we had in persuading public first health officials about mechanical thrombectomy was about cost effectiveness. So they actually had doubts about cost effectiveness of mechanical thrombectomy, and one of our arguments was this work published in Stroke that actually showed cost effectiveness of mechanical thrombectomy in almost all European countries except for Bulgaria. And if you additionally look into quality adjusted life years that actually thrombectomies gained in comparison to best medical treatment, here you can see that the number of quality adjusted life years is almost 20% more in comparison to best medical treatment. So it tells you that this works, it gives results, and it is cost effective. So I will jump to some cases. So this was the first case that we performed. This was a 38-year-old lady that had actually birthday day after thrombectomy. So upon admission, she had left-sided hemiplegia with an HSS 11, aspects 10, and door to groin was actually pretty good for these first cases. It was 3 hours. We encountered several this was obviously a simple M1 MCA occlusion with a first pass effect and ticky-free end result. So what were the obstacles that we had? It was first sluggishness of emergency medicine department staff. They didn't know what to do or where to send. So we as neurointerventionalists actually took over the management of the patient before, during, and after thrombectomy. There was no clarity in the further clinical pathway of the patient. So the patient actually, upon discharge from angio suite, spent additional 3 hours in the emergency medicine before being admitted to intensive care unit at neurology clinic. Of course, all of this has been improved in 2023, and I think that we can finally see the light at the end of the tunnel. So I think the bright future in terms of now increasement of the number of mechanical thrombectomy is ahead of us in 2024. So another patient with this was actually the second patient with and our first tandem occlusion, 64-year-old male patient with right-sided hemiplegia, aphasia, high NIHSS of 17, and relatively good aspect of 9. As you can see, there was a tandem occlusion with the occlusion of proximal ICA, and then another occlusion at the carotid T. So we actually did aspiration on 2 passes, then used a stent retriever with 1 pass, stented the ICA, and the end result was MTK2B with the MRS2 of the patient. Time to groin was 5 hours, and this was because door to groin was 4 hours, but it was 4:35 or something like that. So it was because neurologists actually required brain MRI despite clear CT image of the patient, and then we had to wait for additional green light by primary care physician because the patient was from abroad, from United Kingdom. So what we have learned out of second case, it is that we need actually a protocol of mechanical thrombectomy. So we actually we joined the forces, neurologists, some of neurosurgeons involved in endovascular treatment of hemorrhagic stroke, and us interventional neuroradiology. So we formed a protocol which had been approved later on by clinical center, and it is now part of protocol for mechanical thrombectomy for the territory of Bosnia and Herzegovina. So in our case, there's actually we started with the development of mothership model, where actually the patient is directly transported to the comprehensive stroke center, where acute management actually ensures the application of full diagnostic and therapeutic armory that we have in order to start initial neurological evaluation and, of course, treatment of a patient within the angio suite. Drip and ship and drip and drive. Drip and drive model is something that we actually think of, and drip and ship with the primary stroke center is maybe not too possible, because there are not so many actually hospitals in Bosnia and Herzegovina who have organized neurology service for 24/7. So, of course, being in front of all of these obstacles, and with the reluctance from the elder generation of neurologists, we need to treat sometimes beyond guidelines. So this was maybe a 10th case of male 33-year-old with the prolonged orthogroin and with the occlusion of the basilar artery. It was treated. It was actually treated only with the aspiration catheter with really good result. Then kid 5 years old with pediatric NHSS of 15, again with the prolonged time to groin. This was his initial CT, and actually the referral diagnosis was head contusion, because kid actually felt from the chair, probably during the onset of symptoms. So we had flare DWI mismatch with preserved signal intensity on flare images in the brainstem. So the end result after 3 passes with aspiration catheter were this was this one on the left side. Actually, the PCA was hypoplastic, and there was a good fetal type of PCOM. Then another kid, girl of 8 years with a relatively short door to groin of only 55 minutes. In this case, we used aspiration on 2 occasions, and then stent retriever, and the final result was MPK2B with MRS 2. So you can see this was actually filmed tomorrow, just the day after thrombectomy. And again, so a lot of the cases that we had actually in the early stages of our battle with other clinicians in order to establish mechanical thrombectomy as a must in treatment of stroke patients was actually treating basilar artery occlusion. So another case of proximal basilar artery occlusion treated with aspiration as a first line of treatment, and then with stent retriever for the both PCAs, and then at the end we had to actually angioplasty the culprit lesion, stenotic, and most probably a ruptured plaque at the level of proximal basilar artery. So the result was actually really good. So if you compare number of mechanical thrombectomies, of course, we are obviously we have a substantial lower number in comparison to Germany. However, we actually we had a substantial lower number in comparison to our neighbors like Montenegro and Serbia, and I will not talk about Croatia, because 2 days ago, actually, I got the information from one colleague in Croatia that only Zagreb this year had almost 370 thrombectomies, and whole Croatia around 550 thrombectomies so far. Matters to address that we are actually pushing hard. One is public campaign. We need to make patients aware of the possibility for mechanical thrombectomy, so they can sometimes actually demand that from their physicians in order to actually to speed up things in this pre-treatment part of management of the patient. Then we had a problem, and we successfully solved actually recognition of the procedures, and now we are waiting to see whether reimbursement will be solved, and we have promises that since 2024 it will actually be enlisted as a procedure that is going to be fully reimbursed by Federal Health Agency. Of course, early recognition of ELY, acute ischemic stroke, and the improvement of management is a must, and according to our opinion, it is through introduction of e-stroke platforms. We started to keep records at stroke registry with the all metric data for mechanical thrombectomy in Sarajevo, and something similar is actually also been performed in other comprehensive stroke center in Mostar. So hopefully we'll have some data from our stroke registry to show next year. So thank you again for your attention, and greetings from Sarajevo.
Thank you, Dr. Denis. It was great to listen your presentation. So our next presenter will be Dr. Tsotne Chkikushvili. His topic will be the pre-puncture challenges in developing countries. He is neurosurgeon at American Hospital in Tbilisi, Georgia. Dr. Tsotne, if you are ready, please share your screen.
Hello, everyone. Do you hear me?
Yes.
So, hello, everyone. I'm glad to be here with you. Thank you all to join our webinar. My presentation is about my point of this presentation is that stroke is a systemic. Stroke should be managing stroke should be a systemic approach, and every step that is leading to the growing puncture is very important, and I want to show my personal experience about it. The steps that patient undergoes before the growing puncture. Of course, first step is when patient or his or her relatives see that something's wrong. So they recognize stroke from the patient itself and or from the relatives. Then the call goes to 911, and the paramedics should recognize these symptoms and act respectfully. And after delivering patient to the stroke center, your department also should activate the stroke protocol, and then goes to radiologist, neurologist, and after we do the puncture. So first, there are a lot of mistakes, and there are a lot of reasons that could be that leads to delay of the growing puncture. And first of all, of course, recognition of the stroke by the patient and his relatives. So very important is the preparedness of stroke, or stroke preparedness or stroke awareness. This means the ability to recognize stroke symptoms, and this responsibility lies on the government and on the campaigns that should lead to educate population what is stroke. So I want we all know these banners that could be really helpful, and it should be, I think it should be in Georgia. It's I think very rare when we see something like this, advertisements or some banners or something like this. So from 67 thrombectomies, 70 patients, from my personal experience, called 911 after 4 hours from onset. So there was, of course, the 8 hours, 7 hours. I mean, from my experience, after 4 hours is some kind of line, and median MRS was 4 for those patients. I want to show some pictures of the patients like this. This was a 65-year-old patient with the delayed recognition of the stroke. They called ambulance after 5 hours. Procedure took only 35 minutes with one pace recanalization. You see the excellent results, but MRS was 4, and probably the reason is insufficient education of the people about the stroke. Second is really important and very painful in Georgia, but lately it is getting better, much better. When paramedics are go to the patients and see the symptoms sometimes, and not rare, they take these patients to the wrong hospitals, and then it is very hard to deliver these patients to the correct hospital, because the logistics for that is very complicated in Georgia. And I've seen a lot of patients who are waiting for the ambulance to be delivered to the comprehensive stroke center for 5, 6, 7 hours. So it means that they are without any chances for good results. I think it's very helpful, like in Catalonia, the paramedics use the race scale, or it's much easier than NIHS, but of course NIHS is more accurate. But race scale could be, or there are some other also scales that can be used during this from the paramedics to recognize the LVO and send the patients to the comprehensive stroke center directly, not to the just sometimes even not in the stroke center, so just to the random hospitals. I want to show you the next case with the mistakenly taken to the regional hospital, where there was no neurologist, and they just were waiting for some ischemia to be seen on the CT after 24 hours. This patient's relative called me, and then we delivered the patient to my hospital. You see, it was also very quick recanalization with a good result, but the patient died after a couple of days. We did MRI perfusion. There was some little chance, and it was he was a young patient, so we did a shot, but unfortunately he didn't make it. So I want to go to the next reasons of the delay of the puncture. This is also very important in Georgia, and very sensitive, because in a lot of hospitals there are the ear department are working with the different people. it's very hard to train them because maybe they don't work in this hospital, they just have some night shifts, and they don't know people in the hospital, doctors in the hospital. It's very hard to train them, and that sometimes leads to to some mistakes, like unnecessary investigations. I have seen a lot of unnecessary chest X-rays, which could delay it at least for half an hour, or some ultrasound, or they are waiting for some creatinine test, blood test to do CT angiography because of insufficient education and trainings, and this could lead to some delay. Of course, also they can even sometimes could be that they can't recognize stroke and even they are not called to neurologist. I want to show the next case with the same problem. The patient was delivered to the hospital on time. It was like 1 hour after onset with high NIHSS. She was intubated directly, and there is a gap between CT and CT angio, like 4 hours, and I took the pay. Then there was some because your department told to the relatives that there was nothing acute going on. We were waiting for relatives to decide to do thrombectomy or not to do. So it took a lot of times, and from onset to recanalization was 9 hours or 8 hours. I don't remember correctly, but patient was MRS5. It was really a tough case, but I did it with one PES Sombra method organization. It was not tandem, but with a huge clot from PCOM to M1 segment, and you see the MTK3 recolonization rate, but unfortunately the result it was not good. The next reason also that I've met in doing my practice is inexperienced or undertrained radiologist. We have some problem with the radiologist because I don't know a hospital in Georgia where a radiologist himself is on the night shift, and during the shift is at the hospital. So they are looking at the images from home, and I think it is also a problem. I don't know how it is in Europe, but here in Georgia, you can find any radiologist during the night shift. So only a couple of departments have a rapid system, so we are completely dependent on the subjective opinion of the radiologist. Sometimes if there is a miscommunication between radiologist and your department or neurologist, also it gives the delay between CT and CT angio, and sometimes I've seen not a small amount of cases when radiologists say that there is no thrombus, and in reality there is an LVO. So I always ask to my colleagues that to involve neurointerventionists from the beginning of the process, but it is also one of the problems. I don't know why, but sometimes I think it's for some people, it's for undertrained people, it's not so clear that this is a stroke and this could be treated. I want to show some case. This is a case when neurologist just called me because the patient was in IHS 18, and the radiologist was saying that there is no thrombus and no occlusion, and just in case after 2 hours, the neurologist called me, maybe you will see. So, do you hear me?
Yes.
Yes, sorry. So one more problem that I can also say about radiologists or your department or neurologist. We sometimes they are waiting for the results from the radiologist, which could be 1.5 hours, 2 hours with the official result, and it also can be a reason for delay. And in this case, I just looked to the CT scan, and if there is a undertrained radiologist who is not trained in neuroradiology and vascular radiology, can easily miss thrombus, because this is a multi-phase CT, and as you see, there is a gap between M1 and M2, but the distal arteries are filling from the collaterals, and this was the reason why radiologists thought that this patient had no occlusion. But fortunately, this result was not so bad. And in reality, sorry for the old pictures, but I could not find the better ones. This is from PAX, and this was the real image from the angio suite, and the recanalization was also good, and the patient got better after thrombectomy. Also, there's of course the kings and the queens of the stroke, the neurologist who should decide whether to call you or to treat patients themselves, or to do it with a combination. But sometimes there are some delays. Maybe they I don't know, but there could be some other things to do, or there are some moments when neurologists are waiting for some blood tests. Also, in my experience, they can exclude patients without asking neurointerventionists, like there is no chance for thrombectomy, or there could be no good results after thrombectomy. It is also a frequent skeptic view from neurologists, not from all, but it's we are more aggressive neurointerventionists, and the neurologists try to be more careful, and they want also to wait for results from the radiologist, and this can also lead to some delays. And of course, we are not perfect either, and we can also make some mistakes. Before the puncture, we should I think we should see all the vascular images that we can. We should measure the aortic arch, or we should have some experience. We shouldn't be ashamed to ask questions to our colleagues for help, and we also should be available on time. And we should be careful to when we are shift on call, because in Georgia there is a really big problem that we should also mention, that one neuroradiologist is always responsible for two comprehensive stroke centers. I mean, right now I'm responsible for two comprehensive stroke centers, and This means that I have to be available 24 hours within the 7 days. So this is also a big problem. And of course, for example, now I had 3-hour surgery, open surgery. So if a patient comes to our department during this surgery, there is no one to do the thrombectomy in my hospital, or in the second facility where I'm responsible. So this could lead also to delay to the going puncture, and we hope that there will be more trained neurointerventionists who could join us and do the thrombectomies with us side by side. Also, there are some problems with the necessary equipment that could be problematic, because unfortunately we can't afford all materials in Georgia. For example, there is no balloon, there is not available balloon guiding catheters, and it's problematic. So my last case is the tandem occlusion, where I had no carotid stent, so I had to use smaller graft from angiologist, and unfortunately I got lucky and patient got with MRS 0. But as you see, the graft is smaller than it should be, but fortunately it worked for me. So in conclusion, my goal was that there is like a domino effect, that from the manifestable structures to the common femoral artery, every step is important and should be considered as equal. Thank you very much.
Thank you, Dr. Sotne. And our next presenter had to be Dr. George Kutidze, the neurosurgeon from Tbilisi. But for some reasons, he cannot attend our webinar today. And now our next presenter will be the Nika Kornadze. He is a radiologist, and Dr. Nika Kornadze and Dr. George Kutidze are one of the first neurologists and neurosurgeons who started thrombectomy in Georgia, and it will be interesting to listen to their lecture. So, Dr. Nika.
Thank you. Good evening, dear colleagues. I'm glad to see you here, and I want to speak about my clinics and also thrombectomy and thrombolysis. And it's visible, yes?
Yeah, everything is clear.
Okay, thank you. We know that I'm neurologist and work at neurology neurosurgery department at Stroke Center. In my hospital, Eristavi National Center Hospital, Stroke Center has been operating in a hospital since 2017, and we have thrombolysis cases 223 and thrombectomies 356. Department of neurosurgery, neurology neurosurgery and stroke center includes, of course, neurologists and neurosurgeries, and each member of our teams has a license, of course, and got experience, and according European Stroke Organization, Angels, and we have a specific also nurse got certificates in stroke fields. Then the main what happens, patient comes in a hospital, of course, mainly by the ambulance brigade. This is a main source of patient. According to state regulations, stroke patients are taken to the nearest stroke center, especially if they have LVO clinical presentation, large vessel occlusion clinical presentation. Patient have to go to the stroke center, not stroke units, first of all. The doctors of the stroke center are informed about the arrival of a stroke patient, and we meet in the emergency department, of course. We have information about stroke, and we're in emergency department. Our clinic has equipment, of course, instrument and laboratory possibility, as we use very often CT tape, CT perfusion, and fortunately this machine is near the emergency department, and we don't need a time after several steps, and we start the investigation immediately. And of course, we use MRI scan if it's necessary, especially in wake-up stroke. And sometimes we want to determine time onset of stroke for thrombolysis or thrombolysis window. And also, we have specific programs in our smartphones, and radiologists, neurosurgeons, and neurologists can see these pictures and slides during 24 hours and change the experience, change the ideas, and of course it's so useful for us and so helpful. Also, of course, according to the indications, we start systemic intravenous thrombolysis. A CT scan room, of course, it's possible if it's possible, and if we have elbow occlusion, patient prepared for thrombectomy. Also, catheters in laboratory is near the emergency department, and several matters later, and we use I don't waste the time. We save dot needle time for thrombolysis, and very often start the thrombectomy as soon as possible, immediately during thrombolysis. Thrombolysis ongoing, and thrombectomy starts as soon as possible. We have two arm angiogram, and it's available in our clinic, and thrombectomy is performed by a neurosurgeon. You can see this is a thrombolysis procedures. Woman, 32 years old, on the left side hemiplegia during thrombolysis. Then in a parallel period starts the thrombectomy, and this is a catheters in laboratory, and this patient woman, and starts the and ongoing thrombectomy procedure. Also, after intervention, patient moving to the stroke care unit, of course, and continue treatment based on the guidelines. Secondary prevention, so important. We have to avoid recurrent stroke, so important. And sometimes it's a difficult process, because after recovering, some of the patients try to stop treatments, and neurologists have to start communication firmly, continue treatment, of course, at home, and the rehabilitation process is so important, and we have to start as soon as possible. According our statistic, mortality, of course, we are following and see the patient several months later, outcome 90 days later. And what's about mortality? It was about 5% according to our statistic, and MRS about 2 MRS. And this patient, this is a before treatment and after treatment, you can see. And I want to speak about one interesting case for you. This patient, I got the patient at emergency department, male, 50 years old, chain smoker, low degree of conscience, onset time of stroke 1 hour, PT, sensomotor aphasia, paralysis, facial paralysis, and on the right side, slight hemiparesis, and its score was 8. Then according anamnesis, blood pressure, high blood pressure without control, without treatment, and chain smoker. But according anamnesis, history, on the same day in the morning, he had a TIA, transient ischemic attack, without right hemiparesis, speech disturbances, but without any treatment and investigation, and stayed at home. First of all, I'm a neurologist, and decide make or does not make a thrombolysis, of course. And first of all, I made MRI scan. I wanted to exclude mild stroke in the morning. Sometimes with a mild stroke, tiny lesions, lacunar infarction without any neurological deficits, and similar TIA. That's why I wanted to exclude minor stroke and for thrombolysis. Yes. It's an exclusion criteria we know. What's my MRI scan? You could see TVI regime. You can see this is a lesions here. Also MAP ABC. This is an acute. What does mean acute lesion? And flare regime was negative. It was a hyperacute stroke and inclusion criteria for thrombolysis, and that's why I decided to start the thrombolysis. You can see this is a gradient regime, excluded bleeding, and this is a MRA. This is a carotid artery occlusion. You can see this area, and of course, outcome would be so severe without intervention. And laboratory status was normal, studied RTPA, NH score in patient neurological condition improves, but suddenly worsen. Patient's clinical pictures, NH score became 20, stupor, total aphasia, high degree of central facial paresis, hemiplegia on the right side, and I was afraid, first of all, of course, bleeding. Immediately was made a CT scan, exclude any bleeding, and of course continue thrombolysis. In parallel period, started preparing for the thrombectomy, and you can see thrombectomy procedure here in video. And his vessels, he had problematic vessels because catheter could not go through the vessels, and the neurosurgeonist made artificial dissection slightly and got a way for catheter. You can see this is a healthy area. Okay. And was made dissection slightly, artificial, and we got a recanalization. Then this is a pre and post treatment slides, pictures. And after 24 hours was made, of course, CT scan without any bleeding, without any complication, without any perfusion syndrome. You can see, of course, here similar on DVI regime, lesions, ischemic stroke. And several days later, of course, started the rehabilitation process. And several days later, patient went out from the hospital. NH score was 3, states motor aphasia, slightly MRS, without any paresis in the extremities on the right side, and patient survived without any complication. Thank you for your attention.
Thank you, Dr. Nika, for your presentation. And our last but not least presenter will be Dr. Iago Tsertsvadze, Head of Neurosurgical Department in West Georgia Medical Center, Kutaisi, Georgia. His topic will be mechanical thrombectomy for stroke access in Georgia, on the west side of Georgia. Dr. Iago, if you are ready, you can share your screen.
Okay.
Yeah, it's okay.
Okay, thank you again, dear my colleagues, dear my friend, to accept our invitation during this Christmas period. I will be very fast. Already Dr. Nika explained how they started in Georgia mechanical thrombectomy. Our talk, my talk will be about, sorry. Our talk will be about about mechanical thrombectomy system in west side of Georgia. As you know, already you mentioned that a stroke is one main cause of disability and mortality, and mechanical thrombectomy is a gold standard of treatment of large vessel occlusion. But many European countries still there is no available this kind of treatment. Mostly in developing countries, there are many problems. Also, nowadays there is less information about mechanical thrombectomies and about stroke systems in developing countries. That's why our team did a comparison study from special region, from West Georgia and West Ukraine, with collaboration. Professor Andrei, he did already his presentation. We did our comparison study from West Georgia and West Ukraine to compare our results. What's the main problems to have a good comparable results to as developed countries. As you see here, it's West Georgia. My colleague Nika is working in Tbilisi. He already mentioned he have started 2017 this kind of treatment. I'm working in west side of Georgia. Kutaisi is a second large city in Georgia. Population is about 1 million. Territory is about 31,000 square meter. We have started 2019 before national stroke system, and it was a little bit easier because all of the hospital belongs one corporation, and inside of one corporation, it was more easier to start this kind of treatment because already we had some software to share our images. One comprehensive stroke center is located in my city, Kutaisi, and we have two stroke units. One is in the same city, and one is located 100 kilometers away from Kutaisi. Second country from West Ukraine is a Lviv region. As Andrei already told us, they have two comprehensive stroke units, five stroke units, and main mechanical thrombectomy is doing in a Lviv region. And 7 hospitals covering 91% of the Lviv region within 60 minutes distance. What's about selection criterion? As usually, we are selecting large vessel like M1, M2, basilar artery, ICA. Also, we are accepting tandem occlusion. We are using CTA to select patient, to see aspect score. Also, some selective cases, MRI. Nowadays, we are using rapid software. What's about as I told you, we have started in our hospital in west side of Georgia in 2019 to do this kind of treatment. Nowadays, we have done more than in 2023. We did more than 30 cases. It's not this data is not up to not upgraded. And in West Ukraine, they did more than 300 mechanical thrombectomy. We used data from last year, 2023, like 75 patients. And as you see here, mostly as I told you, we had a large vessel occlusion patients, just one case distal occlusion. From both groups, TK3, TK2B was more than 90% of cases. What about anesthesia protocol? From M1, ICA, T carotid, we are using local anesthesia or mild or moderate sedation. And first, our choice is if patient has M1 occlusion, we are doing simple adapt technique. If interact angulation is good for ICA, we used stent, largest stent retriever and biggest lumen aspiration catheter to see fast pass recanalization. You see here M1 occlusion after just simple aspiration, adapt technique. For M2 basilar artery occlusion or tandem occlusion, mostly we are using general anesthesia. You see here proximal basilar artery occlusion. After simple aspiration, basilar artery is opened, but the patient had a right side vertebral artery chronic occlusion, maybe some atherosclerosis disease. But as you see here, collateral flow is good. That's why we did not decide to do rescue stenting in an acute stage. Patient after 3 months, after 6 months, she was rehabilitated fully. What's a tandem occlusion? As we know, there is no consensus nowadays, need or not rescue stenting. Our first approach is to remove intracranial thrombus. After that, ballonoplasty. If it's not working, then rescue stenting. As you see here, from both group, good MRS 0 or MRS 1 was the same, but in our group, MRS 6 mortality rate was more than Ukrainian group. What is it? Main reason? As you see here, in Ukrainian group, time from onset time from symptom onset to admission was about 2 hours. But in our group, time from symptom onset to admission was about 4 hours, because of we did not have national stroke system and emergency service. They don't have information where they should transfer patient. From our group, on door to groin puncture was like 2 hours. Total median time from stroke onset to groin puncture was like 421 minutes, unfortunately. And as we know, system should be established to have like 20 minutes from arrival, at least 20 minutes after arrival. We should have in brain images. In Ukrainian group, on door to groin puncture like 120 minutes. But as you see here, from median times from stroke onset to groin puncture is about 234 minutes. In West Georgia, endovascular treatment ischemic stroke is manageable. It's a patient arrive very soon, and as we know, it's require very good network connection, and organizational logistic chains are highly needed in our regional healthcare and within the hospital to maximize workflow. Nowadays, our government is working to establish national stroke system, but there is many problems. According many guidelines, our population is 4 million, and 4 million inhibitions needs like a maximum of 5 stroke comprehensive stroke center and about 12 primary stroke centers. Also, as everyone knows, to have like one software to share images, maybe it's mandatory to minimize transfer time from one hospital to another hospital. Nowadays, in some hospitals, for example, in our hospital, we have a rapid system, but they don't have connection with stroke units. It's a main problem why we have delay patients in our hospitals. Thank you again. Thank you again. I appreciate. Sorry. Thank you again, my dear friends and colleagues. Appreciate your time to accept us during the Christmas time. And in 2024, we are waiting in Georgia to make on-site workshop or some conference. Actually, we are planning to organize like hybrid webinars in Georgia, and all of them are invited. And we will be happy to come in our hospital, in our country. Thank you, Dr. Vladimir, especially very thankful for Ivan. He made a collaboration with Smith. Without him, it would be actually impossible to make this collaboration. Thank you, Professor Andrei. We did this collaboration study, and in Marcel, they accepted us during the vascular section. Thank you, everyone. Thank you, dear Denis, my Georgian colleagues, and hope you will come in Georgia again. Thank you. Thank you, dear David, also from Barcelona, my friend and my teachers.
Okay, and thank you everyone for attending our course. So I wish you Merry Christmas and Happy New Year. Thanks. Goodbye.
Thank you. Goodbye.
Thank you.